Good evening, everyone. Here Imran Abbas. Again, we are live. I am live from Dubai, and Professor Arun Prasad. He's a well-known bariatric surgeon at the globe, and he's one of the pioneer of bariatric surgery in India. And also, I can count many positions like president of Indian Society for Obesity, and also in different positions in one anastomosis gastric bypass association. In IFSO, always you can see the contribution of professor, especially for promoting bariatric surgery. So as my viewers, we have finished 4 interview series, and now we have started revisional bariatric surgery. That is the most important, because nowadays we are facing redo surgeries. We need to discuss about this. So in this interview series, I have invited someone who are expert in revisional surgery, who are dominant in redo surgeries. Hope this interview series will be fruitful, especially for you. Sir, again, so much thanks, Professor Arun Prasad, because always you are supportive, always you are encouraging. And due to this, we always invite you and really disturb you. It's great honor for me, sir. Sir, please.
Thank you. Thank you very much for those kind words. And congratulations for doing such a wonderful job. And this webinar series of yours is popular all over the world. So congratulations for that. As far as revisional surgery is concerned, I don't think there is anybody in the world who can say I am an expert or I am experienced, because the number of revisional surgeries are few, and all of us have done few surgeries only. And meetings like this, where we can have a discussion on our combined experience, is what helps even the speaker to learn and do better job for their patients. So thank you once again for doing this wonderful service to the bariatric surgical community.
Sir, so much thanks again. And really, because already I have asked you, you are really supportive, encouraging. And in future also, we need your support. Our main target to use this social media, and this is the best way to convey our message to youngsters. And when I interview someone like you, personally, I learn a lot. This is reality. So, sir, how you define failure of bariatric surgery?
Ah, so firstly, I have a strong objection to this word,
Okay, sir.
failure. I think this word failure is something very negative, and it creates a negative feeling for the surgeons, bariatric surgeons, as well as the patients.
Okay, sir.
For example, if somebody has a hernia surgery and the hernia recurs, nobody calls it failure of hernia surgery.
Absolutely
When
agree.
the patient goes for surgery second time, it is not known as failed hernia surgery. So why should we say failed bariatric surgery? Why can't you say recurrence of weight? Why can't you say relapse of the problem? So when such terms recurrence and relapse are available, then the term failure, I have strong objection to that.
Absolutely.
However, when it comes to the definition is if a person has not lost more than 50% of excess weight, or if the person starts regaining weight before 2 years or 5 years, then the second one is not a very clear definition, but that is how people would define, in inverted commas, failure. So when we say excess weight loss, so that means if somebody is 150 kgs and their ideal weight should be 90 kgs, that means excess weight is 60 kgs. If you have lost less than 30 kgs, then that is how we call this as a failure.
Sir, excellent, excellent. And so, what is because you have definite, Tom? I know. Still, we have limited experience in revisional surgeries, but you are one of them who are leading this one redo surgeries definite. So again, so your experience is dominant as compared to someone who are still doing primary surgery. So because this interview, our target, so is little different as compared to webinar. In webinar, a legend like you have maximum 5 minutes, 10 minutes to talk, but here we have sufficient time and we can a little, still we have not sufficient time, but again we can highlight. So what is the technical consideration in revisional surgery? So there are some issues, this is not like primary surgery.
Okay. So the technical issues is that patient has already had one surgery or maybe two surgeries. So first thing that we'll find is presence of adhesions. So we are going to find adhesions in the upper abdomen. All these surgeries are happening somewhere around the liver. So the moment you enter, you will find the left lobe of the liver stuck to your anastomosis or staple line. And moment you start freeing that, you are going to get bleeding and oozing. So this is the number one technical problem that one would face. Unlike a primary surgery where you go inside, put your Nathanson retractor and lift the liver up, here you don't do that. Here when you go in, you are faced with a problem of separating the liver from the surgical site. So that is one. Number two, you have to define the anatomy, and the anatomy varies from person to person. Many of the revision surgeries which people do are on patients who have been operated by somebody else, because patients, when they have a failed surgery from one surgeon, they want to go to a new surgeon for their second surgery. So it is quite rare that we do revision surgery on the same patient, except in situations where I would say we are doing, correction or some kind of, uh, revision in the sense that you are correcting your earlier situation. Like, you're removing a band and doing a sleeve or a bypass, or you are doing something like that of your old patient where there has been a complication. So like a stricture has taken place or a leak is taking place, then in those situations, probably you would be reoperating. They would not face so much of a problem. But patients who have come to you after 2 years, 3 years, 5 years, there the adhesions and this oozing issue is there at the start of your surgery.
Sir, excellent. Sir, key points. So as you mentioned, there is lot of adhesions. There is also adhesions of this left lobe, because this message will go especially for our youngsters. So if they are going to start, definitely they must be under supervision of someone who can do this, and also a teamwork. There is no doubt tertiary hospital, no doubt, must be in situation where all facilities are there. But again, there are also some technical points, key points to go ahead. Can you explore, sir?
Yes. So the next point would be if there is some kind of a bowel anastomosis. So you would need to free the bowel anastomosis, and that freeing again can be tricky at times. Then the other technical points, you need not use the word technical, but other key points are that these patients, even if they have regained weight, or there are patients whom you are doing revisional surgery for excess weight loss, they would all have some kind of malnutrition, because these are the patients who have not responded well to the surgery, and perhaps these are the patients who have not followed your and your dietitian's instructions correctly and have got an imbalance. So pre-operatively, going through their diet pattern, what they are eating, going through their malnutrition, in other words, deficiencies, because many of them will have deficiency of protein, B12, thiamine, vitamin D, calcium, and all these deficiencies would be there. So these deficiencies have to be documented before you go for surgery. Otherwise, you can be blamed later on for having created these deficiencies. Try and correct to whatever extent it is possible these deficiencies. For example, I will take an example. If you have got a patient of excess weight loss, then these patients of excess weight loss or hypoproteinemia will have low albumin. And there, if we are going to do a revisional surgery whereby we do a gastrogastric anastomosis or do a reversal of your earlier bypass, then that anastomosis chances of leak is very high because these people are actually malnourished. So in these patients, it might be a better idea to do a feeding gastrostomy through the gastric pouch. So whether it is a Roux-en-Y or an MGB, it doesn't matter. If you do a feeding gastrostomy, you can build up the patient and then do the surgery at a second stage. Although I know there are people who would do it at one stage. But as I said right in the beginning, none of us have that kind of an experience where we can say, oh, I have been doing it like this and I don't have any problem, because all of us have done few cases of each type and the variety is tremendous. So when we do revision surgery, there are lots and lots of types of things where you have to do revision surgery. It's not like the recurrent hernia where you know that, okay, hernia would have recurred and we will go like this. Last time it was laparoscopic, this time it will be open. Last time it was TEP, this time I will do TAP. So it's not like that. So it's not something like doing a subtotal cholecystectomy and then going back and doing completion cholecystectomy, because those are standard. So every time you will see the same thing in those cases, and there your previous experience helps. Here, most of the time, your previous experience is not going to help because every case is going to be different.
Yeah, sir, excellent, excellent. Really, it's a definite a great message for our youngsters, especially when they have decided to do any type of revisional surgery. Sir, my question is specific to weight regain after a sleeve gastrectomy. So yes, we have weight regain after Roux-en-Y also. Maybe we face also after OAGB. But my question is weight regain after a sleeve gastrectomy, when you decide, or failure of weight loss. So patient cannot or could not achieve that target 50% weight loss. So still, because patient must lose if 90 kg, but after 30 kg, 40 kg stuck. Now again starting, okay, when you will decide to go for surgical intervention.
Okay. So as we said, after sleeve gastrectomy, there can be two situations.
Yeah.
One is inadequate weight loss.
Yeah.
And second is weight regain. So talking about inadequate weight loss, when we talk about inadequate weight loss, there the patient has to be evaluated for their diet patterns. Many times correction of their dietary habits helps in the cycle to restart. So there could be a temporary break in the weight loss graph, and this correction can restart that weight loss. Then some kind of physical activity like exercise. So if we encourage the person to do more exercise, muscle building exercise, because after surgery, however much you tell the patient, they'll try to avoid physical activity. They feel that, oh, I've had a surgery, I should take rest. But to encourage them to do exercise, especially muscle building exercise, which will increase the basal metabolic rate, so that also kickstarts the weight loss. Finally, these days we have also started adding pharmacotherapy. So in India, we've got available the new drug which is semaglutide in its oral form, and I have personally used it in a few patients. And there, what I feel is that the addition of pharmacotherapy temporarily kickstarts the GLP-1 response, which had gone on a temporary hold. So it does not mean that the patient is put on lifelong semaglutide, but maybe giving it for 2 or 3 months helps in reviving the graph of weight loss. If everything fails, then you need to do a volumetric CT to see if your sleeve has actually dilated or the sleeve was inadequate to start with. If there is any such problem where you feel that the sleeve has dilated or the first surgery was incomplete, then there is a role for doing a revisional surgery. And when I say revisional surgery, we have lost most of the advantages of a restrictive procedure by doing sleeve. So when I do a sleeve revision, I would prefer a malabsorptive procedure. And in my country, personally, I would prefer an MGB OAGB in such patients. If you find that the sleeve was perfect and there was no problem in the sleeve, then you have to be very guarded with the result. One of the first sleeve revisions which I did was on a young girl and she had not lost enough weight. And I made the mistake of saying, oh, don't worry, I will do a sleeve to MGB and you are going to lose another 20 to 30 kgs. But she hardly lost 5 kg. It was very embarrassing for me to face that patient and face their parents because I had promised 30 kg weight loss in the OPD. And what had happened is that she had a very perfect sleeve surgery in the past. So, if a good sleeve has not worked, then the chances are that your good bypass also may not work. And in these cases, revision surgeries quite often fail. So, if your first surgery was good, be very careful in offering a second surgery. And maybe here you can tell the patient that, sorry, we cannot help you much. You've had a very good surgery, and I don't think bariatric surgery is meant for you. We can try some pharmacotherapy, and it's better to say no to such patients than to make a promise to them and not be able to deliver.
Sir, excellent message, really, because obesity is a chronic disease and also multifactorial disease. This is not only one factor that you have highlighted, and also this is amazing. And also, this we need this interview. This is, in my opinion, beauty of these interviews. Now I am talking with someone who is explaining his own experience, not this data, that data, who write this, who. And in my opinion, this interview series is at least 5 years ahead to the text. So these things will go then in paper and then in text. It will take time. And this thanks social media. Now our viewers have access to such a person, and also he's sharing his own experience. Sir, another question. So regarding BP limb, because you know better than me. So what is your protocol? We are talking about weight regain after a sleeve gastrectomy. You have decided, yes, you are now, you used pharmacotherapy, everything. Now you have decided you are going to do OAGB. So what is this BP limb for your patient, especially after weight regain?
Okay, so I would go 50 centimeters more than what I would normally do in a primary MGB OAGB. So there the demography also makes a difference. For example, I have spoken to surgeons in Europe and they say that less than 250 their patients don't lose enough weight. In India, if I do 250, most of these patients will get lot of nutritional deficiencies. So if I am doing 150 to 180 centimeters on a regular basis, I would do an extra 50 centimeters when I am doing a revision of sleeve to MGB. Here also it is important that you measure the entire bowel length. People don't measure it in regular primary surgery. But here, when you are going to give an extended bypass, please measure your uh, total bowel length,
Yes.
total bowel length, and you must leave at least 250 or maybe 300 centimeters distal to your anastomosis.
Sir, excellent. Sir, regarding gastric pouch, so if you see, yes, already you have mentioned you prefer to do the CT volumetry. Yes, there you can see this is dilated pouch. Are you prefer to resize?
Again, I don't have so much of an experience. And what happens in these patients, I have not been able to convince the patient that, listen, I am going to resize it. Let's see if it works. If it does not work, we will do a third surgery of a bypass. So therefore, I have not been able to experiment this. So I personally would do a bypass rather than a resize. If while doing the bypass, I find that the sleeve is over dilated or too much dilated, then yes, I can trim it out a bit. But generally, I will leave the sleeve the way it is, because if the sleeve has failed once, we leave it and let's try a new recipe.
No, no, sir. My question is, we are doing OAGB, we are doing MGB. Yes, any type of restrictive, we are adding that male absorptive component or hypoabsorptive component. But this OAGB, because I don't need to mention someone. My question is about resizing of this pouch. If dilated pouch, you are doing OAGB, but there is a dilated pouch. Is it compulsory to resize to this sleeve pouch?
No, that's what I said. I
Ah,
will not do anything to that sleeve pouch
okay.
because you are increasing the chances of leak. If it is very dilated, if it appears like the first surgery was highly incomplete, then one could consider it, but generally avoid doing a resizing.
Okay, sir.
Resizing might be essential if you are doing a conversion of sleeve to RYGB, because there you need a small pouch. And this is the reason why I said I would prefer a sleeve to MGB, because here you can do the surgery quickly without the need of resizing your sleeve.
Sir, another question regarding, because why I am asking about a sleeve revisional, because most of this area, especially where I am sitting here in Middle East and also our viewers, so the most common surgery bariatric is still at the globe is a sleeve gastrectomy. And now we are when facing, if we compare, yes, I remember just 5, 6 years ago, I revised many band. I put band a lot and I have revised as well. But nowadays we are facing a sleeve gastrectomy. Due to this, I am asking, highlighting this one. So still, I am weight regain after a sleeve gastrectomy. Is it necessary? There is no GERD symptom. We will also talk when GERD. Now, only weight regain. How you prepare the patient? Is it compulsory in this patient to do upper endoscopy to check de novo this GERD or reflux? And what you do to prepare this patient?
Yes, I think an endoscopy is must in all these patients, because you can rule out, any esophageal lesion, stomach lesion, the presence of maybe a twist in your sleeve, which was done part of the original sleeve. There could be a small stricture there. So all these things have to be evaluated. So I think an endoscopy is a must.
Sure. Sir, now we will again, patient after sleeve gastrectomy and suffering with GERD and also no response to as well as this patient lost weight. Patient BMI is now 23, 24. There is no high BMI. BMI is in normal range, but really intractable GERD. And when you evaluate, there is also migration of sleeve. So what you do in this case, how you prepare the patient and what is your preference?
Yes. So in these patients, one will have to consider doing a bypass, but the limb length need not be what you would do for a standard bypass, because here you are doing this procedure mainly to change the pressure dynamics. You want to convert a high pressure system in the stomach to a low pressure system by doing a gastrojejunostomy. So a liberal size of the gastrojejunostomy is important. Freeing the stomach and trying to bring it down back into the abdomen and a crural repair is also essential in the type of patient you have mentioned.
Excellent, sir. So these are the key points. If someone is doing, must reduce this stomach that already migrated, and also crural repair, and this is also compulsory. Sir, are in your experience, so have you faced, you did this, you did Rowan Y, everything, and again this migration occurs. So this, have you faced such a situation?
Luckily, I have not faced such a situation, but if that happens, you might have to go for more drastic procedures like an esophagojejunostomy,
Yeah.
which has its own problems.
Yeah, it's on. Absolutely agree, sir. Sir, about weight regain after Rowan Y gastric bypass. Yes, we are facing also this situation. How you deal? Are you prefer only distalization or need something? So we, sorry, we must see the pouch, we must see the gastrojejunostomy, and how you see the role of endoscopic bariatric surgery.
Yes, so in these patients, like I mentioned earlier, our first step would be to go through a dietary recall, look for any deficiencies. Sometimes small things like, patient has vitamin D deficiency, you correct the vitamin D deficiency and the weight loss starts again. Then we are looking at the pouch and the anastomosis dilatation. So in this situation where you have a pouch or an anastomosis dilatation, an endoscopic suturing of that is an excellent option, and you do an endostitch and reduce the size of the gastrojejunostomy. That is an excellent option which we have. The other option which we are looking at would be to reduce the pouch size or even put a band. So you can go inside and put a ring to add to the restrictive procedure. If you want to add to the malabsorptive procedure, then you will have to distalize your anastomosis and increase the BP limb, because BP limb is most crucial for weight loss.
Sure, sir. Sir, excellent. And you have highlighted key points, especially we must rule out vitamin D deficiency. Again, why we are professor highlighting this. So no need to rush for revisional surgery. Please, MDT, role of multidisciplinary team. This obesity is a chronic disease. This is not solution, is not only surgery. So different thing. The last option is surgical intervention. So this is very important message. This interview, our target is, main target is this, to convey this message. So how many times you want to do a surgery? So this only surgery, and because this dietary habits, healthy life, so many things involved, then you can decide about. Sir, regarding marginal ulcer, that is also a challenge.
Yeah, sure. Before going to marginal ulcer, just let me complete. I mentioned vitamin D, so it's not just vitamin D, it's also giving more protein to these people, asking them to do exercise, asking them to increase their muscle mass so that the BMR increases, and correction of other vitamins. B12 also makes a difference. And if there is an issue of diabetes, then a simple medication like adding metformin or at times acarbose. Acarbose, basically what it does is it slows down the breakdown of carbohydrate. Even that can get you a weight loss of extra 5 kg, motivate the patient, or trigger a restart. So as you rightly said, surgery is the last option. Please do not jump into revision surgery. The surgery has complications and the results are not as good as they are from surgery. Sorry, you are going to ask some other question.
Sir, yes, we will go ahead just again in this discussion. So regarding exercise that you have highlighted, so we must go for muscle making. So definitely you prefer patient must go for gym.
Yes.
Sir, how you so define this exercise? How many days like this? Half an hour per day is sufficient. 1 hour
Yeah.
per day is sufficient. Can you explain?
So, right. So I think the target should be half an hour per day for 5 days a week.
Mm.
And there you have both a combination of aerobic and anaerobic. So you can do some cardio, warm up, do some stretching. It's very important that you have to take care of your joints. There are what are known as non-impact exercises for obese people. You can go to YouTube and look for exercises. You can do a lot of exercises just sitting on a chair. And in addition to the aerobic, you need anaerobic exercises whereby there is what we call as resistance to your muscles. And only when there is resistance to your muscle during the exercise will your muscle building take place. Before going for the exercise, say half an hour before, do a little bit of carbohydrate loading. So you can maybe take a banana, and this is essential. Otherwise, during your exercise, you might end up with protein breakdown. So you want to avoid that. So take a little bit of carbohydrate half an hour before. After you finish your exercise, within the next half an hour, have some good protein intake. If required, to start with, you can even consider protein shakes and protein supplements, but try and take natural protein as far as possible. So those are a few words about the addition of exercises.
Sir, so much thanks. Sir, regarding marginal ulcer, that is also a challenge. And as we all know, routinely we face such a situation in smokers. Sometime, yes, patient so promise with you, I will not smoke, and also many things. And also maybe for some time they will not smoke for 1 year, 2 year. So patient lose weight, he forget everything and now start smoking. And when consult to you, so there is marginal ulcer, no response to. Personally, I have faced such a situation that I am asking, and unfortunately, so this was a disaster for myself, for patient, and he was chain smoker and also for quiet smoking for 2 year. Again, start smoking. No intractable marginal ulcer, no response to any medicine. So now we have decided patient BMI is in about 25, 24, so normal range. So what you do in this case?
Okay, so now this is a tough situation. So marginal ulcers treatment starts with diet. You need to give diet which helps. Lifestyle changes. Then PPI is very important, and these PPI have to be usually in double dose compared to what people give for duodenal ulcers and other problems. And then worst case scenario for the marginal ulcer, you may need to revise your surgery. And sometimes, if it's an MGB marginal ulcer, then you may have to revise it to do a loop bypass or a convert to an RYGB.
No, sir, my question, just patient is Ruan Y and
Mhm.
smoker, and maybe again he will start smoking. So this marginal ulcer is intractable, no response to any type of conservative therapy. So in such a situation, just I need your opinion. So is it better to completely reverse in normal anatomy?
Worst case scenario, yes, you have no choice but to do that. And otherwise, you can consider a revisional, because if it's an intractable ulcer which might perforate, you can revise. In something like MGB, where you have a long pouch, you're not so scared because the pouch is long, you have extra option. But worst case scenario, yes, you'll have to convert it back, reverse.
Yeah, sure. Because there is no other way. Because this patient, same condition when patient is using NSAIDs. Maybe when you did surgery, there was not using, but now patient is using NSAIDs. And also there is no other way. Patient will use NSAIDs. And also again, we are facing such a situation, intractable marginal ulcer, any type of gastrojejunostomy or gastroileostomy. So my question is this: so in such a situation, So now patient is MGB, but in normal BMI. BMI is okay. So uh, we can also reverse to normal anatomy. Maybe patient again gain weight.
So, it's just too bad. You have to tell the patient either you smoke or you have the weight. And if I reverse, if you are not careful for your diet, then you will regain weight.
Sir, again, I will explain another question because these things daily basis we are facing. Patient is smoker, weight gain after sleeve gastrectomy. Patient is smoker. So now, then we have some limited options. One option is also sadi. So when we
Yeah,
do
I was going to say that SADI would be an option there because
yes,
SADI is not prone to ulceration, but SADI has its own problem. It's a more difficult surgery, more technically challenging surgery, and a higher risk of leakage after this.
sir, have you experience of sadi in such of cases?
Yeah, I think I've got an experience of 4 or 5 cases.
Revisional surgery.
Revisional surgery, yes.
You prefer if there is such a situation, it's better to go for such a situation that we can achieve better results.
Yeah.
Sir, again, so because if we are talking about weight regain in MGB or OAGB, have you faced any case because you are routinely doing MGB?
Yes, I have faced a few cases of weight regain after MGB, and so far we have managed them by pharmacotherapy only. We
Okay.
have, I have given them the option of, a revisional MGB whereby we will increase the length of the BP limb, but none of my patients have opted for surgery, so I don't have the experience of telling you of that.
Sir, regarding weight loss or micronutrient deficiency, sometime so patient will go that side, decline. And you will see, so you did any type of hypoabsorptive surgery. Now patient lose weight. And have you faced such a situation and what we must
Yes.
do?
Yes, in such a situation, firstly, you will have to try and get the nutrition back to a reasonable amount, which could be by doing a feeding gastrostomy in the remnant stomach or by giving TPN. Once the patient is little better, then you have the option of either completely reversing or you have the option of reducing the BP limb.
Sure, sir, sure. Sir, in especially that you have mentioned, so we can reduce BP limb and then patient can gain the weight. So in weight regain, in such if patient is suffering with bile reflux, you have mentioned, then bile reflux I am asking, not this is just marginal ulcer or GERD. Documented bile reflux after MGB or OAGB, then we must go for Roux-en-Y gastric bypass, as you have mentioned.
Yes, see now when we say documented bile reflux, if
Endoscopy.
you do an endoscopy
Yeah.
to document bile reflux, you will find that almost 20 to 30% of these patients will have bile reflux, which is understandable because you are connecting it to the biliary system. You have a BP limb. However, only about 2% of these patients have what is known as a symptomatic bile reflux. So when it comes to symptomatic bile reflux or bile reflux causing esophagitis and further complications, then yes, I think the answer there would be to go for a Roux-en-Y bypass and add an alimentary limb.
Sir, my target is also those cases because when I am asking bile reflux, gastroesophageal reflux, because bile in stomach or bile gastritic or presence of bile after OAGB is common, as you have mentioned. But sometime if we have bile in esophagus, then must change to Roux-en-Y gastric bypass,
Yes.
as you have highlighted.
Yes, quite right.
Yeah, yeah. Sir, regarding because again we have a lot of question about this MGB as well. Sometime what we face because this is the long pouch, there will be a small twist there will be a small twist. Maybe surgeon during surgery has no idea, but after the patient is not relaxed. Have you faced such a situation?
Yes, there could be a small twist. And here the answer is, if you made a wide enough gastrojejunostomy, then that will take care of this small twist, because the food is going to pass from high pressure to low pressure. And moment you create a larger opening there, then that twist can be compensated to a certain extent. If you find the twist happening on table, then you have the option of untwisting it and maybe giving a fixing stitch between your pouch and the remnant stomach so that it becomes straight. And you have the option of revising it on table while you are doing the surgery and creating a fresh anastomosis.
Sir, again, I will ask a previous question because I need your opinion, because some of expert, they have this opinion. Due to this, I am asking. In case of bile reflux, when I am asking bile reflux, mean in esophagus, not in stomach, they are
Yes.
preferring to do bronch anastomosis. Have you any experience, or are you agree?
See, bronch anastomosis theoretically sounds very good, that you've made a side to side anastomosis between the two loop and the bile should go from there to there. But I am not sure if the bile is going to understand what you have done, and whether the bile is going to follow this nice new route, or if it will go back and cause reflux. So personally, I have not done this procedure. People I have met, some people say it works well, some people say it does not work well. So there is no final answer to this question as yet.
Okay, sir. Sir, one of the surgery that we routinely ask. So, in case of GERD in a obese patient, so what is the gold standard that till this time we hear is Roux-en-Y gastric bypass? That we are hearing about this. Yes, we must go for Roux-en-Y gastric bypass. This is the gold standard in case of GERD in obese people. So we will not go for fundoplication or something like this. We will go for Roux-en-Y gastric bypass.
Quite
This,
right.
this is the gold standard. Are you agree with this? So what is my
Yes.
question? Yeah. What is my question? So in case of kid, so in especially because we were talking about not reflux. Reflux is yes, okay. We will go in OAGB or MGB. Only GERD patient has pain, and when you will do there is no reflux, no bile in esophagus. Yes, bile gastritis. There is no marginal ulcer. There is no endoscopic finding, but patient has pain. So we complete this because also we are facing such a situation. So yes, you can see little gastritis is there. Yes, you can see, but there is no typical marginal ulcer. So what is your opinion and how you deal in such a situation?
Right. So these patients, they all need a manometry and pH study.
Okay.
And if sometimes your manometry is going to show that the problem is because of dysmotility. And if the problem is because of dysmotility, your surgery is not going to help them. If there is no dysmotility and the pH study shows that yes, there is an alteration of the pH in the esophagus during your 24 hours monitoring, then in these patients, surgery would help. So I would rely a lot on pH and manometry study.
So then we will go for Roux-en-Y gastric bypass.
I think that both Roux-en-Y as well as MGB help in these patients, an MGB with a long pouch or a Roux-en-Y with an alimentary limb. They both help in these patients. Now, the problem is that the results are not 100%. So when the results are not 100%, then out of 10, if I convert 10 patients of these to MGB and 2 out of 10 do not get a good result, they go for a second opinion. Then some friend of ours is going to say that, oh, MGB was the wrong procedure to do. You should have had an RYGB, which is the gold standard. So to avoid such criticism, many surgeons, even though they know that an MGB would have helped, they go for the safer option of RYGB, because if the patient does not get symptomatic relief after RYGB, they will not be criticized for doing the wrong procedure. So this is a little bit of a tricky situation. And for this reason, even though I believe that an MGB would give an equally good result, I will be doing RYGB in these patients.
Sir, excellent, excellent. And also these are the key points, because when we are doing Ruan YSP, sorry, when we are doing such a situation, we are facing such a situation where we have decided. So this is not only surgery. We must take help from, as an endoscopist. We must take help as a pH metry, manometry. Then it will be easy for us to decide, is surgical intervention is fruitful for our patient or not. Then when we will decide such a situation, definite, then there will be less chance of any type of complication. Sir, my question, we face very rare, not routine, mesidoblastosis. Have you faced in your experience?
No, I have not faced this problem and I really don't know how to deal with it. So this
Yes.
question I will pass.
Sir, regarding dumping, so that is also an issue. In my opinion, this is not blessing. Dumping is really issue, because when we do any type of surgery, patient want to remain relaxed. So how you deal dumping, and if you will go for surgical intervention, what you will do?
Okay, so for dumping, firstly, the usual stuff you'll have to do: small, frequent meals, have more fiber, and one medicine that helps a lot in dumping is acarbose. So acarbose 50 milligram to be taken as first bite. So when you start eating, take acarbose as a first bite, 50 milligram. Many patients have been helped with this because that slows down the breakdown of carbohydrate. It not only helps dumping, it also helps in your diabetes resolution. It helps in adding to your weight loss. It helps in keeping the patient feeling full and not having any, desire to eat extra food. So that's a very useful medicine. If it comes finally to uh, reversal of surgery because the symptoms are so severe, I have not had any patient who has come to me for which I have had to do reversal, but I have read about it and I have heard about it that if the symptoms become extreme and patient says, I cannot live with this, then you have no option but to reverse the surgery. And both RYGB and MGB can be reversed quite easily, so it's not a problem.
Sir, sometime also this due to dilated gastrojejunostomy, we will face such a situation, and also we can do
You can consider an endoscopic suturing and reducing of that lumen. Yes, that is an
size,
option.
and then that will be definite beneficiary for our patient.
True.
Sure. Sir, excellent, really, and definite. It was, in my opinion, one of our best and also very fruitful discussion. So, according to your opinion, because now we have many discussion, we can discuss a lot, but I highlighted the main points that routinely we are facing, our youngsters are facing in their routine practice. And next interview series will be about complication, and definite I will invite you in those in that interview series that will be after in we will start in July 2023. We will highlight complication and we will start, and also that will be also beneficiary. Sir, now so who is eligible, because this message will be for our youngsters, who is eligible to do revisional surgery?
That's a difficult question as to eligibility or who should be allowed to do. I think people who have done 1,000 bariatric surgeries should have the experience to tackle a revision surgery without any problem. My personal advice is when you are doing a revisional surgery, call one more surgeon, call two more surgeons, two colleagues of yours. Revisional surgeries are very rare. So supposing you are my colleague, you do 10 revisional surgeries a year, I do 10 revisional surgeries a year, we call each other for the surgery, I gain 20 case experience per year, you gain 20 experience per year, and together we are able to think better, because as I said, no two surgeries are the same. Every time you will face a new situation, so two brains are better than one. More importantly, if something goes wrong or if there is a problem, medico legally you tell the patient that, listen, this is a complicated surgery, I had another surgeon here with me, so two surgeons were there for your surgery, and if you are having a problem, that means the problem is genuine, not because of any mistake by me or any inadequate training. So this is my suggestion, that teamwork for revision surgery.
Sir, excellent, excellent. And also, I like this message from person like you to our youngsters. Again, no need to rush for revisional surgery. That you're thinking, this is not like this. When you will go inside, really you will stuck. Just imagine that professor earlier mentioned, when you will see adhesions of this left lobe, how you will, and then you will face, there is also migration of stomach, migration of sleep. So what you will do? So definite, when you will be 2% sufficient experience, that learning curve complete, then we will, you can do easily. Sir, same related to this, which center, according to your opinion and your experience, is center of excellence for revisional surgery?
I cannot name any such center, but there are many centers. Like in my country, in India, we've got about 10 to 15 such centers where good revisional surgery work is being done. One point, as you mentioned about difficulty, very small thing. The person who has done the surgery before you, while firing the stapler, had some oozing from multiple points. And at each of these oozing point, he has put a Liga clip. When you go
Lot
for
of
your
addition.
surgery,
Yeah.
you will not see those Liga clips. You are going to fire a new stapler, and that stapler which you fire, if it goes over the Liga clip or over the cinch of an ESG patient, that stapler is going to misfire. It's going to open up then and there, and you will be in trouble. So, small things are there which you need to be careful about.
Sure, sir. Excellent. Sir, your message for our youngsters who are youngster, they are doing surgeries, their number is good, and now they are listening you, especially a message for them. Any message?
Message is, if you ride a horse, only then you will fall. There is a saying in India, which in the local dialect which we have, that only those who ride a horse will fall off the horse. So that does not mean that you don't ride the horse. If you do surgery, you will have complications, you will have problems. Obesity of that patient is not something that you have created. So if that patient gains weight or does not lose enough weight, don't blame yourself. You have not given that disease. Sometimes God's will is at a higher level than your will and your desire to help the patient. So don't take it personally. These things happen. And as I said right in the beginning, I object to the term failure. Because the moment you say failure, the surgeon also goes down. He becomes defensive. That, oh no, my surgery has failed. I am a failure. He starts thinking that he is a failure. But it's not a failure. It's a recurrence of weight. It's inadequate response to the weight. You may have done a good bypass, but the patient is not producing enough GLP-1. That's not your fault.
Yeah.
And the amount of GLP-1 which is being produced is not enough for that patient to lose weight. The body has adapted. Patient is cheating. Patient is eating things which you have not told that patient. When they come to you, they say, no problem. I had one patient who said, oh, I only eat this much, I only eat this much. In the evening, I got a phone call from his wife saying that, every day he comes back, he has one big plate of noodles. Without that, he's not going to go to bed. But when he comes to me, he says, no, 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 I only eat this much. So there are, as you rightly said, multiple factors. and don't let this dissuade you. Don't let this make you lose your morale. Please carry on with the good work. Go by evidence-based medicine. What is correct? What is today the best procedure for your patient? Do that procedure and leave the rest to the Almighty.
Sir, really appreciable, really very effective. Always your talks is like very effective and very fruitful. And hope for my viewers, these talks, these interviews are really effective. And also I received a lot of response. And due to this, I have continued this interview series. This all is sport for my viewers, from my viewers. And my viewers, so much thanks. This time also now sir is here and late night in India. Now in Dubai is 11 o'clock, 11 p.m. But again, at that part of what I think it must be 12 ahead. I think 1,
Yeah,
1 a.m.
yeah, almost there. So
Yeah,
thank you and
1 a.m.
congratulations for doing this wonderful service to the bariatric surgical community. All the best.
Sir,
And
so
I
much
look
thanks.
forward
And
to.
sir, also I invite you, I will share with you the link. We have started GLR ebook with the help of a Malaysian company. And that is
Okay.
amazing. You can add your videos, you can add your text. This is amazing. And also this will be like a app in mobile, and everyone can see your video. If someone want to see any type of video from Professor Arun Prasad, just he will search and he can see. This will be a short text, short pictures, and also short video. Like tips and tricks. This is tips and tricks. I will share with you now, and you can
Okay.
add, and it will be great honor if you add your
Thank you.
videos, any type of video. So MGB, OH, this Rowan Y gastrectomy, revisional sleeve gastrectomy. Sir, it will be really great honor, and you are always sportive. And my dear, next week also we will be with another legend, with another expert in revisional bariatric surgery. Always Tuesday, 10 p.m. Dubai time. We have such a sessions, that is interview series. And so much thanks, my viewer, due to your support. I will continue this series, and also always it is encouraging for me. Sir, again, so much thanks and have a nice time.
Okay. Thank you. Good night. All the best. Bye bye.